Happy Global Health Equity Week. Our agenda today is to talk about, what is Global Health Equity Week? What does it mean for HIMSS? And then we'll focus on our speakers today, Carolyn and Ian. They'll be giving us some information about what's taking place in their programs around Washington State birth equity and the Maternal Mortality Review Panel. And then we'll have a little bit of time for some Q&A. So first of all, a little bit about our Global Health Equity Week. What is health equity, first of all? Essentially, it's being able to provide equal access to anyone, regardless of their geographic location, their ethnicity, socioeconomic status, gender, or demographic factors. So they should have access to health and wellness, regardless of all of these things. We want to be able to celebrate the transformative power of health information. And then also it's a time for us globally to come together to start this movement of change. So action-wise, what does that look like? You could be an advocate for underserved groups to improve care access and outcomes, advance the elimination of health disparities, find real-world solutions, and develop resources to address challenges. So getting folks together on this platform to kind of share real-life instances, real-life solutions that they can implement in their community. Be a champion, as well as start conversations with local leaders around this arena, and then of course share insights, best practices, and resources, as I had mentioned. So the goal of the week really is, as I mentioned before, is improve access to healthcare for all our communities. And so this year, HIMSS has focused on 3 topics: digital health literacy, social determinants of health, and then maternal health. And so for our topic today, we've selected maternal health. And then a little bit about our speakers. We have Carolyn Sedano, who's a program manager from the Washington State Department of Health. And then we have Ian, who's a director and also a professor at UW. Great, so I'll hand it over to Carolyn.
Great, thanks, Joanna. Thank you for having me today. So my name is Caroline. I'm the perinatal program manager at Washington State Department of Health. Just a little background on the perinatal program. So this includes the Washington State Maternal Mortality Review Program, the Washington State Perinatal Collaborative, which is our state's PQC implementing quality improvement around the state, as well as our birth equity project, which I will be sharing more details about today. I'll start though by sharing some background on the maternal mortality panel. And I think Ian will probably share some more later. So this is a program that was established in 2016 and made permanent in 2019. The legislation has DOH collecting and reporting data on individuals that died while they were pregnant or in the 1-year postpartum. We do this by working with a panel of 80 experts that have a background in perinatal clinical care as well as community-based perinatal services. They review each case of someone who died in Washington to determine the cause of death as well as other contributing factors. And they make recommendations for each case, and then those are all pulled together along with data every 3 years and published in a report to the legislature. The report is quite long and has a lot of recommendations, but summarizing as much as I can into one slide, the high-level findings from the report include that 80% of pregnancy-related deaths in Washington were preventable and occurred after the end of pregnancy. The leading cause of pregnancy-related deaths in Washington are behavioral health conditions, and that includes substance use and overdose, as well as suicide. Substance use is associated with about 20% of the pregnancy-associated deaths in Washington, and American Indian Alaska Native people face higher maternal mortality rates than any other race or ethnicity. Like I said, there's quite a few recommendations in the report for the healthcare system, for community organizations, for facilities, and for policymakers. But these are bucketed in 6 overarching categories around undoing racism and bias, addressing mental health and substance use, enhancing healthcare quality and access, strengthening clinical care, meeting basic human needs, and addressing and preventing violence. I'm not going to share too many of the recommendations from the report. I was just going to highlight two that are tied to our birth equity work. So when we think about addressing racism and discrimination and bias, one of the recommendations was to fund community-driven initiatives that address structural racism, social drivers of health, and promising solutions to prevent inequities. Related to the fifth recommendation on supporting basic needs for pregnant individuals, a recommendation included here is to integrate perinatal support providers, such as doulas, community health workers, patient navigators, social workers, and peer birth workers into perinatal care practices. So I'm going to shift into sort of what we are doing at the state level to implement birth equity recommendations coming out of the panel and the work we're doing with community. So a lot of that work sits in our birth equity project. So the goal of this project is to reduce racism in the perinatal system. We do that by funding innovative and community design programs that their goals are to improve health outcomes, including addressing maternal mortality. And we partner really closely with community leaders and birth workers around the state. As I think when I was thinking about what would be helpful to share, I wanted to include kind of our framework for what does birth equity mean and how we're partnering with community. So we worked really closely with an equity consultant as we started building this project. So I'm just going to read some of the kind of North Star guiding principles that we've used before I get into some more about the program. So what we have found when we're thinking about working with community is that we need to understand the concept that communities are not experiencing adverse outcomes because they lack money, resources, or programs. They're experiencing this because they lack control and say over the money, resources, and programs in their community. We need to shift our focus on not just investing resources and programs into these communities, but working strategically to ensure that those in the community have decision-making power over the resources and programs in their community. And there's, many reasons why that's hard and challenging for not just government organizations, but any large institution to really partner effectively with community members. And so some ways that makes this challenging, institutions and systems maintain and perpetuate the power dynamic towards community by creating barriers for what can and cannot be done. No matter if they have intentional or not, they exclude community from working with institutions to have decision-making power over their communities. I'm sure we're all familiar in our, big systems of how challenging this can be, but certainly time constraints, policies and procedures, resource distribution, and structure and hierarchy can all make this a really challenging partnership to build. But I'll just end this kind of section by saying, listening to the community, sharing power, and developing accountability models are necessary for the government to reduce harm. This is the framework we're building towards and measuring our impact by. So I think this is really important for the work that we're doing around birth equity is not that we shouldn't just be focused on reducing the negative health impacts that are impacting certain communities and addressing health outcomes, but also shifting power and decision-making so that those communities most impacted have not just a say, but are really leading the work in what we're all doing to address those, to trying to change the health outcomes in those communities. So this is a bit of a process of then how we started implementing birth equity work at Department of Health. So in 2021, we started a birth equity advisory committee. This was composed of doulas and community birth workers and other folks with lived experience that are from the Black, African American, African diaspora, and American Indian, Alaska Native communities. So this group started meeting in 2021. And this group selected 2 community facilitators to do community engagement prior to making any funding or program decisions. So they selected 2 organizations that were from the community. So folks that we funded a Black doula organization to do outreach within the Black doula organization. So Department of Health did not do the community engagement. We hired other folks to do that community engagement. And then that community engagement, our contractors gave us sort of reports on the findings from those community engagement that they did. Those were presented to our advisory committee, who then met throughout kind of a fall of 2022 to develop a funding opportunity. So that group developed eligibility requirements, scoring criteria, and I'll get into a little bit more of what that looked like on the next few slides. And then that group is the one that decided where funding was going to go. So they made the decisions about who would get funded, and they also were able to provide some feedback to who the funded partners would be, of like sort of any feedback they had about the applications and projects. And it was interesting, folks that had had different experiences working with large institutions. Repeatedly, there were times where they were like, okay, can you tell us when we'll hear if our recommendation will happen? And I kept having to be like, you're like, this isn't a recommendation. Like, no one's going to come back and say, like, we're going to do it differently. Like, what you say here is what will happen. And so that was even at the very end, we had a meeting with the final recommendations for funding, and people were still like, when will we hear if these actually happen? And I kept having to be like, no, 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 like this is what will be funded. So anyway, just as a reminder of how challenging sometimes that like power shift can be in actually working with community. So I wanted to share some of the findings from the outreach that we did. I have some of the summarized findings up on the screen here. I won't read through all of them, but I just want to highlight that, the racism as a barrier to accessing care comes up a lot, of not wanting to experience racism, negative experiences, like a assumption that there will be met with racist experiences when they enter the healthcare system came up a lot. It also, we talk a lot about vicarious trauma, like the experience of birth workers who both have experienced racism and also are continuously witnessing their clients experiencing racism is just a continuous burden that impacts everyone who's trying to mitigate the impact of this. Another thing that has really stuck with me is, almost as a way to handle some of the racist experiences is that need for allyship amongst the birth worker community, that functioning alone can be really challenging when you're constantly in challenging spaces around discrimination and racism. So having that partnership and allyship is really vital. So I'll go on to, once we shared these findings with our advisory committee, on the next slide I have, this is what the advisory committee determined as their vision for birth equity in Washington. So a lot of this is, thinking about, one thing that we found was a lot of what this came down to was the birthing experience, so that they can have the birth the way they want it. They're treated as experts in their own care. They don't have to have experience the fear of discrimination and violence. And that there's an opportunity to utilize traditional practices, when they're used like Western medicine. So again, as we think about who we wanted to fund, who we wanted to partner with, and how we evaluate that work, how do we define success, we were led not quite towards like what's the health impact, but more like what's the birth experience that people are reporting who are benefiting from the funds and services that we are doing. So we ended up funding 8 different organizations around the state. I won't go into all of them, but we have some representation on the eastern side of the state as well as western side of the state. And they're all, one thing I will just share, one of the important factors in making a funding decision was that the organizations needed to have a leadership staff that reflected the community being served. So they're all staffed by folks that reflect the community being served. There was a definite, I think, weariness in our community engagement and outreach of an organization with maybe one Black staff member being given funds to support that community. So we tried to ensure that who we were funding had that staff makeup as well. So I'll share a little bit about some of the organizations we funded. This is Shades of Motherhood Network in Spokane. They have been able to train 2 cohorts of Black doulas serving the Spokane community. Onto the next slide, Blackberry is based in Burien. One thing that I really love about the Blackberry model is Jasmine, who is a single practitioner, I think she started out as just being an independent doula. These funds have allowed her to scale up her services. She now has a full staff. She has an admin. They moved into a new physical location. And she also pairs her doula services with lactation support, human milk bank. So she has resources for people that are breastfeeding and chest feeding. And then she also has a resource materials, so people can rent materials and bring them, not rent, I think they can borrow materials and bring them back. And it's just it's becoming more of a community hub for folks that are going through their birth journey. Uh, and then Ion Maternity serves the immigrant community in the King County area. A big focus of what they have done is doing these education and outreach events in like libraries and YMCA's to just share like what is a doula, what is that? Because they hear repeatedly in the immigrant community that they don't see a doula as something that they can access. They see it as like a very middle class, white service. And so just making sure folks are aware that it's something that they can access and they can access someone who speaks their native language has been a huge just outreach and education for their community. So I wanted to share just like my wrap up themes of some things that we've learned about working with these community-based organizations. So something we talked about around like how we're sustaining the organizations that we're funding. So a big theme was the desire of having a physical space and being able to use funds to have a physical space. So we funded some organizations where it was someone who, you know, was a solo practitioner who would meet people in their houses and like didn't have that physical space. And so that's allowed them to like hold trainings in their space, build community, offer decompression spaces for doulas that are out in the community doing this work. They're storing materials. So just like having that physical space, we've seen a number of our grantees have just been able to thrive when they have literally just a physical space to like convene and hold their and work in. And similarly, like I mentioned, a lot of the organizations we funded were like one or two folks, and this was like their first funding opportunity. So they didn't have any other grant funding. So this really allowed them to move beyond just a independent practitioner into an executive director, a CEO, be able to like really grow and turn their work into more of a business, which was exciting to see. We hear a lot about, oh, if you can go back to the previous slide. We hear a lot about the role that culture plays. I know that's sort of obvious, but I wanted to call out, spelling error here. This is food, culture and food. Food comes up a lot as something that funding should be able to support integration of food as a way to connect with community, connect with other birth workers. It's just, and there are a lot of grant funding doesn't allow food, but the embrace of food as a way to like do birth equity work, we hear again and again is really important. Burnout is something that significantly impacts the community birth worker workforce. We've heard that there's sort of a 4 to 6 year burnout rate for a lot of community birth workers. So thinking about how having a physical space, integrating food, having that mentorship and allyship within these communities organizations can really potentially address burnout. It's a larger issue, but having funding that supports not just service delivery is something that is really important when we think about addressing burnout. We've also seen really good benefits of our organizations connecting together. So we have the organizations that we fund come together throughout the year, and we also have office hours. And we've seen just organically, a couple of our organizations have decided they're sister organizations where they like have been able to build sort of informal networks and sometimes formal relationships where they share resources, they share training materials, and they're just able to stretch their resources further by collaborating more closely. Looking ahead, I did want to mention the birth doula certification and Medicaid benefit as we think about sustainability for who we're funding and this population, this workforce doing this work. There's a certification that is live now, and then starting in 2025, the Healthcare Authority will be rolling out their doula Medicaid benefits. So we're working closely with our funded partners and the Healthcare Authority to see how that will impact folks that have been very grant funded reliant now, and how does a community-based organization led by a lot of people who are very passionate about this work integrate into like more of a traditional healthcare provider. So that is, I think, like looking ahead where we see a lot of opportunity, but also challenges as people are navigating that new system. To wrap up, I'm going to share kind of my own reflections about working with community-based organizations and ongoing work around equity. When we think about the funds that we used, capacity building has been really important. Again, not just funding service delivery, but how do you think about someone who maybe got into this work because of their own personal traumatic birth experience or just a passion for this, and they're shifting into a CEO status? Like, how are you supporting that person take on a leadership role? that organization might be the right organization and the right person to do the work that are meeting your goals, but they might not have the infrastructure to do it. So can you fund them to have admin support, hire a CFO, like all those things that like make an organization actually able to like complete their own vision is important. Again, I mentioned this already, but the staff and board need to reflect the community being served. This was an eligibility requirement we had for funding, so just having that as a really clear expectation moving forwards is important. We also heard that like funding around equity work should go towards addressing economic justice and providing jobs and leadership opportunity in the communities whose health outcomes you're trying to impact. It shouldn't just be funding to do the sake of like the work that you're trying to do, but it should provide jobs, it should provide opportunity and like build wealth in that community as well. This is something people say a lot in equity talks is like relationships, they move at the speed of trust. So we started 2 years in advance of actually making any funding and formal contracted partnerships. So we took 2 years to really build those relationships. Not everyone has that flexibility, but I think it does help as you're, if this is a newer thing that you're embarking on. I supervise the contract managers who work really closely with our funded partners, and it is really emotional labor that they have to do to support our partners. They regularly come to me and share the traumatic racist experiences that our funded partners are going through. So it's a different type of work being in a big institution, but being confronted with that lived experience of the partners that you're working with. So just having that ability to have reflective supervision for your team that's doing this work, I think is also very important. Being transparent about boundaries and expectations with community, this ties into building trust. I think just being really clear from the beginning what you can and can't do. We had to be really clear about, we have flexibility on who we can fund, but we don't have flexibility on like providing funds up front. We have a reimbursement model. So we need to be clear that like we can't fund an organization that can't float the money before getting reimbursed. So being really clear just about like where we're flexible and where we're not. And the last thing my last reflection here is just how we think about shifting power as we think about decision making, as that being your approach to equity, as being like we're letting go of some of that power over decision making, that being realistic about where you are in your own journey with that and being comfortable kind of letting go of the decision making or leadership, and that is been the North Star for us of really saying we're here just to hold space and facilitate, but all the decision making and suggestions will come from the community most impacted, and we will go with what they say to do. So that's all that I had today. Here's my contact information. I'm happy to answer other questions, but I'll turn it back to our facilitators.
Well, next we were gonna have Ian do his portion. Did you want to go ahead and put your video up, Ian? I will.
Well, I was thinking that the video is probably better after my
Okay.
presentation, so make a little bit more sense.
All right, so I'm gonna stop sharing mine. Okay.
Great. All right, and I'm gonna try to make that. Okay, here we go. So hello, everybody, and thanks so much, Caroline, for that really great introduction. There's a number of things that are overlapping here, so I'll just focus on the things that are distinct from what was already presented. The Maternal Mortality Review Panel, as was mentioned, is a group of healthcare providers, community members, people who are allies of maternal health and outcomes, and we review cases of deaths in pregnancy in the year postpartum. I'm a family physician. I do obstetric care as part of my work. I also take care of kids, after delivery and through the whole life course. We have obstetricians and pediatricians, et cetera, in addition to pathologists and other folks who are involved with reviewing what happened with a particular death and how that can be used to inform interventions to reduce the risk of that happening again. That is a very exhausting experience just for someone who's on that committee. And social determinants of health, that's the term we use now for things like poverty, lack of education, lack of health care, low income, the lack of resources in general are highly associated with the majority of these cases. And so one of the things we decided in that work, and I'll just go on to my next slide there, this is our most recent report, and there'll be another one coming out, a more recent one in October of 2025, just so people are aware of that. As a result of doing that work, we really felt within the group that we wanted to do something in complement to what the Department of Health is doing with regard to their focus on reducing racism, which is one of the major outcomes and recommendations that we see over and over as we outreach to communities as being an obstacle to engagement in care and as being associated with poor health outcomes. So we actually developed something called that is an engagement program and outreach program that's part of the Maternal Mortality Review Panel. And that has come in several forms. We do community partnered work. So what that means is we have a diverse set of people, again, with involvement in some way with the health of birth parents in pregnancy and the year postpartum, from a diverse community, particularly those that are affected by disparities in maternal mortality. And that we work together. I'm at the University of Washington, and the kind of core administrative group for this effort is at the University of Washington, and these are efforts funded by the Department of Health in Washington. But we do not think we know the answer to these things and want to make sure that we're making decisions about how to outreach to communities through that partnership product. So phase one of our work was a practice change effort in which we were working to help clinics that were serving communities that were most affected by maternal mortality in improving their ability to identify and treat behavioral health causes of maternal mortality, which together are the leading causes of maternal mortality. And we had a specific aim of getting outside of the King County area because that tends to be an area that gets a lot of resources relative to the rural communities and tribal communities that are outside of King County. That was a bit of a just general idea and goal. And what we found in that first phase is that we really ended up with mostly people in clinics that were in the I-5 corridor, and we had no involvement of rural communities and no involvement of tribal serving health clinics. So we reassessed what we were doing and took a different approach in our second and third phases. We just have the second phase here, which was to move to actually getting out to communities and finding hosts within communities across the state that would then be able to activate their local networks and use it as an opportunity to disseminate the findings of the MMRP report, and then to engage with local solutions to complement those, the ones that are being focused on currently through the programs that Caroline mentioned, particularly focusing on racism. But what are the other more local and very specific solutions that might be identified, which may be relevant only to that area, but are more likely to be relevant across the state? So we started out with an echo session. This is a very popular, or echo sessions, very popular format for clinicians It provides CME. It's a case-based approach to getting information out to clinicians, and clinicians just are very used to that approach where you bring your own cases in on the topics, and the topics were all the major causes of mortality in pregnancy in the year postpartum. In complement to that, we had listening sessions where we went out and presented major findings of the MMRP report to the legislature, and then had a chance for community discussions. And I'll be showing a video in a moment from one of those. Most recently, we've transitioned from an emphasis on getting information out and then getting some feedback to flipping that around and getting some information out, but mainly looking for local solutions, which we're now in the process of completing our final report on, and also trying to figure out what we might do next based on what we've learned so far. These are just a few photographs of the most recent listening sessions and community engagement efforts that we've done. So these activities that you're seeing there are basically identifying potential solutions for their community, which are then rated and prioritized based on a variety of group processes. And we had some very good engagement, overall with these different convenings that we had. A number of very concrete and specific solutions that are community-based, and which we're sifting through now and preparing for the Department of Health as a product of our efforts. This is just another kind of image of how the group would identify particular topics and then prioritize them from the particular work that they were doing. Okay, so I think I will stop there on that part and then go to show a video. And actually, I think I might need to stop share and then share again so that I can do it right. So I'm gonna do this, and I'm gonna share sound and optimize for video sharing. All right, so that should work, and we'll go back to the videos. And so this is from we held a convening with the Hummingbird urban tribal serving midwifery group that is in the Seattle area. And this is one of the videos. They hosted and ran the program themselves for this particular convening.
My name's Vanessa Lovejoy-Garan. I'm indigenous to the islands now known as the Philippines. I am our birthkeeper doula program manager for Hummingbird. We felt it was really important to host this as a community event to center stories of indigenous Native parents. I especially feel, as far as like the review panel, a colleague had actually begged me to apply to be a part of the panel. And I was like, okay, one more thing on my like to-do list. It's part of my job, and it is part of my job. Maternal child health is my job. And so I said, okay, well, I don't have any fancy degrees, but I know birth, I know postpartum, I know lactation, and I carry those stories with the families we serve. And so I applied, and now, and primarily they asked me to apply to be on the panel was because they didn't want to be the only person in the room that was like, wait a minute, we shouldn't, this case isn't done. Like, I need to know more. This was their point of view, like to review really each individual case. And on the current panel, I see a more wide variety of lenses that I feel like the Department of Health did a really good job of like, okay, let's see what they see. Like what I see isn't necessarily what you, doctor person, might see, you know. Especially with those like postpartum, like I'm really curious about the near misses and then the you know, those postpartum events, and I don't want to have a majority of the room being like, okay, we're going to keep going. It's like, no, I want to know more. So I think that's really important. But also, it's not just like a women's issue. It's a community issue. I think one nice thing about this event is that there were more men in the room, and because it's not just about our women and babies, it's everyone else who carries them and takes care of them, and so it's our entire everybody's responsibility.
Great. So we're now in the process, as I mentioned, of reassessing how effective we've been and what we think that with our community partner group, what would be the next thing that we should do to carry this work on and build local capacity to work on these issues across the state. I think I'll stop there.
I just thank you for all of that information, both you and Caroline. That was really, really good to hear. One of the things that kind of surprised me, which maybe it didn't surprise you, but that so many of the deaths that you're looking at were postpartum. So after, you know, they weren't during birth, I assume, and they were after, because I think that we hear a lot about access, you know, not so much in Washington, but you hear about access for women to just getting prenatal care just because the numbers of available practitioners are dwindling, especially in states that now have, you know, less women's rights overall, that there are folks that they just don't want to practice there, or they have these deserts where they have, you know, it takes me 2 hours to get to somebody to provide prenatal care or more because there's no one in my county. Was it a surprise to you that this was the pattern of deaths beyond, you know, into the postpartum first year versus more during birth and or beforehand for complications?
I mean, I'd love to make sure that Caroline gets a chance to talk about that. But I can say, as a clinician, I was invited to come in to join this particular panel because of my expertise in perinatal mental health and death by accidental overdose, both by suicide and accidental overdose. That's an area of particular focus of my research and clinical work. And it really was a amazing epiphany, I would say, and role that the Department of Health in Washington and other MMRPs in states across the country, that's dawning awareness that the full year postpartum is really perfectly reasonable to think about effects of pregnancy on people's health going forward. And that the importance of thinking about mental health, and there's been an increase globally in the understanding of this, but it is really an innovation, I think, of the U.S. health system and coming from the Centers for Disease Control and Prevention and others, understanding that mental health is so important to keep in mind here, and so that's why so deaths by suicide are not traditionally part of the training that obstetric providers, midwives, OBGYNs or family physicians who are doing OB think of as being an important part of maternal mortality. And so, by broadening the lens and understanding that pregnancy and the postpartum period does impact mental health, we're able to see that death by suicide is such an important contributor, a major cause of maternal mortality in the U.S., and probably only not in places because people aren't looking for it, which was our case for us as well. But most of those deaths happen between 6 months and 12 months postpartum. And so there's actually a reduced risk of suicide in pregnancy that compared to people who are not pregnant. But that is probably people putting off, being able to rally for that pregnancy period, and it just doesn't, you can't make it further than 6 months postpartum. And that is not a time when we've historically had a lot of services for people who are birth parents. It is the one of the major reasons. It was a very important part anyway in the legislature in Washington deciding to extend Medicaid funding for people who would not otherwise be covered through the full year postpartum because of these findings. So it's just, a really great thing about being in Washington where there is this recognition and, folks like Caroline and others at the Department of Health really paying attention to this stuff.
Does anybody else have a question before I jump into another one? Okay, so maybe this is more for you, Caroline, on the, I was just at something a couple of weeks ago, a few weeks ago that was had a whole it was mostly health systems. So, think of the larger health systems. I won't reveal who these were necessarily, but they were talking about, their role now in community outreach. And of course, they don't do a lot of the community outreach. They partner with others that do the community outreach, but they're now feeling the pressure to, especially with value-based care, to make their population healthier, right? Which is making your population healthier also involves keeping your patients alive. And some of the findings that they've had and surprises that they've had where they've just thought, well, traditional medicine will just go out and tell them that they need to take their diabetic medication as an example. And they're like, we don't want to hear that from you. And the way that you're presenting it. And I see that very similar to what you're discussing with your, with how you're getting, doulas that are of the same ethnicity, et cetera, in there. So do you work with helping these smaller, the funded groups that you have? How do they actually get connected with these larger health systems that are in the place of, yeah, we're going to have to provide value-based care now. We need to partner with somebody that can go into the community that can represent us, because when you take a large name and say, hi, we're, this big name that you see on TV, that's when you're kind of getting the resistance. But is there an organization or something that is with the Department of Health helping kind of align some of those efforts from the big health systems to use those smaller funded ones to then really reach the people that they actually serve?
Yeah, this has come up a little bit. I guess I will answer to the extent that I can as like not a member of that community. We on the one hand don't want to tell our funded partners like what they should be doing with the funding and resources. So it's really up to them. Like if that's something that they want to take on, they can. I think what I do think is important to remember as like the institution is thinking about this as a process. Like it won't happen at one event. Like building trust will be a process. So it likely will be to think more long term of like what's maybe our 5-year or 10-year goal for like community engagement and like building that trusting relationship, because you're overcoming many longer years of like a bad relationship or distrustful relationship. So thinking about it more of like, what can we reasonably, like, where do we begin? Like, what's a small win? And it's a lot of like, what people say about working with community, working in community, I think what they mean is relationships, is that it's a trusting relationship and that you just have a relationship. Because so many of these organizations have been shut out, have tried, they have tried and they have been met with bad experiences. So yeah, I mean, I think there's, it'll be it's a process, I think. And, you know, we, like I said, we try not to sort of be, dictate what our partners do. So yeah, like there are some that have a good relationship with the facilities in their area, and some that are really clear about not wanting to work with facilities and they don't see that as their role. So I think it really, like to Ian's, a lot of what Ian's work is doing is building local capacity. It will really depend on like the
What do they
organic
need?
relationships that are happening in communities already.
That's great. Well, I know that you have a hard stop at 1, and we very much, very, very much appreciate your flexibility, especially with our technical issues today. So this was really great information, and we are going to send this out to our larger group that was signed up. So very much appreciate it, and thank you for all the work that you're doing. This was super, super helpful.
Yeah, thank you for having us.
Thanks, you guys.